All right, good morning. My name is Bill Scarlett. I'm a reconstructive breast surgeon. I've been doing clinical surgery for 20 years, but I want to talk to you about cancer survivorship and the things that have changed over the last year. So NCCN guidelines, ASCO guidelines, they are all changing as we start seeing more and more survivors, which is great. The medicines are working. However, we now need to focus on how are we going to treat these people. So someone I'm going to talk to today is to challenge my tech colleagues in order to address some of these needs. So the NAPBC, which is the overseeing group for any certified breast cancer program in the United States, they changed their policy as of this year, where cancer survivorship starts the day of diagnosis. So this is a big change. It used to be that it wasn't until you finished all of your treatment that we considered that you needed to go into cancer survivorship. And this includes surveillance for other cancers, because certainly you're at risk if you've been diagnosed with one cancer. ASCO guidelines, they now are including nutrition, exercise, fertility, sexual health, but also mental wellness. And this is something that I think we really have missed the boat on when we talk about our cancer survivors. How do we address this? So let's start there. We know that 80% of breast cancer patients who are diagnosed are going to develop PTSD symptoms. These can show up in a week, a month, a year, and obviously run the spectrum of symptoms. I can tell you in my practice, I am sure that I have missed this because I am not asking these questions of my patients when they come in. We know the drugs that we're giving our patients can add to depression. You know, certainly taking someone who's 36 years old and just been diagnosed with breast cancer, putting them on an aromatase inhibitor and slamming them into menopause at 36 years old is going to add to their mental health issue. Here's a study that they looked at breast cancer patients who had also a diagnosis of depression. Increased mortality with these patients. So the question is, what are we going to do first to identify it, but then to treat it? Two different studies, one looking at breast cancer patients, 21% of them developed depression after diagnosis. Of those that were diagnosed with depression, 22% of them, it was severe depression. Second article here looked at severe depressive episodes and the use of antidepressants. And in the United States, that tends to be the SSRIs. They looked at anyone who had comorbid conditions. So this could be somebody with HIV, this could be somebody post-stroke, but they also had a cancer subset. In the cancer subset, they found that SSRIs only worked about 40% of the time. Well, guess what? That was the exact percentage of the group that got placebo. So it's showing us that these are not working for our cancer patients. There's something else going on, and we're not addressing it well. We know that exercise itself, for all of us, including our cancer patients, will help with depression and anxiety and distress. So why is this not a part of our standard protocol when someone is diagnosed with cancer? We know that in Australia, it is standard of care. If you're diagnosed, you're going to get a program that includes exercise. We haven't done that. We have started doing the research though. When you look at from where we were in the 90s to last year, over 2,600 randomized controlled trials that addressed exercise oncology. What's happening? Well, they're still trying to figure this out. So here's a study from last year where they drew blood. They had somebody come in, they drew their blood, they had to do 10 minutes of low to intermittent or medium, moderate exercise, and then they drew the blood again. They saw their T cells, their B cells, their natural killer cells, your immune system, all those numbers went up. Now this was time and intensity sensitive. So the longer you're doing it, the more intense it is, the more your immune system is going to be improved. That helps us with recovery, that helps us with our actual treatments. Here's a great study looking at post-diagnosis exercise and mortality. They looked at, let me see if I got that, yeah. So what they did was they looked at over 6 million patients that had been diagnosed with cancer. of all sorts of types. This specifically, the highest numbers were in prostate, lung, ovarian, and colorectal. What they found was, for those that ended up doing the exercise, and what was the exercise? So they asked them to do 4 sessions a week of 30 minutes of low to moderate exercise, or 2 20-minute sessions of intense exercise. What they found was all-cause mortality dropped by 25%. So what does that mean? They're not only talking about the cancer coming back, they're talking about stroke, heart attack, suicide. All of those dropped by 25%. Now, as a clinician, if I stood up here and our colleagues that are the life sciences were listening, and I said, I just developed something that can drop your all-cause mortality for any cancer by 25%, they would drag me off this stage in order to invest in it. Here we have it. Get off the couch and exercise 3 to 4 times a week. But here's the other aspect of it. So here are the results, 11,000 patients that they looked at in this one. It doesn't surprise me that cardiovascular endurance, the muscle endurance, the flexibility, that all should go up with exercise, right? But look at the others. Quality of life increased by over 50%. Now, feeling more positive about life, feeling supported, those are all things that we talked about that we're causing with cancer diagnoses, but we're not giving them a way in order to try to improve it. What about our metastatic patients? We've always treated these patients as fragile, right? We shouldn't push them, just hopefully keep them going along with the medication. Well, here's a study that did 9 months of moderate to intense exercise with metastatic patients and showed not only an improvement in quality of life, but decreased their cancer-related fatigue. This was just presented at ESMO, the European Society of Medical Oncologists in Barcelona this summer. Great study. They had 821 breast cancer patients that they gave watches to or Fitbits to, and connected them to a digital platform that was purely virtual. So everything was done at home. And what they found was that they saw an improvement in the quality of life after the intervention, which was 4 months. However, when they redid the survey 8 months later, after people had not been engaged in the platform, the results had dipped back down almost to baseline. So again, what is this telling us? We have to be engaged with them on an ongoing basis, right? I patted myself on the back when I convinced a local gym to give us 3 months of free membership for any patient that was diagnosed in the cancer center. Well, this study is telling me I'm really not addressing the problem. They may go to the gym and they certainly may, enjoy the fact that it's free for 3 months, but unless they're engaged in some sort of platform on an ongoing basis, those results are not going to be sustained. Obesity, okay? This looked at over 6 million patients with cancer. What they found was 4 to 8% of all cancers can be attributed directly to obesity. And for our oncologists, obesity is going to increase your side effects from any treatment that you are giving to that patient. So what did they recommend? Structured exercise and dietary support. So what do we tell our patients, right, when they ask? What do we do? Well, obviously, from my standpoint, I'd like them to see a dietitian. But when they walk in, and this is what they've been looking at, right? I mean, how confusing this. And as a clinician, I can tell you, I've had very little training in nutrition. So, and I obviously have a lot of feeds, and it's this week it's drink 3 cups of coffee, and next week it'll be don't drink any coffee. So it's very confusing. What I do is I try to tell them to avoid the standard American diet, because you could not create a better diet to feed cancer, right? It is ultra processed, it's high in fat, low in fiber, it's quick and easy, but it is not healthy for us. And again, we've got plenty of studies that show the blood work that shows we are just presenting an environment to help feed that cancer. And why? It's causing inflammation. It's causing stress in our system. So when people ask me, and again, I'm not a nutritionist, I usually tell them, do the best you can to eat more fruits and vegetables and avoid ultra-processed food. So, when they push me on that, I say, okay, if it's advertised on TV other than avocados, do not put it in your mouth. Everybody asks about drinking, right? I'm glad I'm not doing this right before happy hour. But the reality is that the recommendation currently is 1 drink or less per day for women, 2 drinks or less for men. I will tell you, last night I ordered a glass of wine. I got at least 10 ounces. So truly, 5 ounces of wine is not very much. American Cancer Society is saying that 6% of all cancers can be attributed to alcohol. 4% of all cancer deaths can be attributed to alcohol. But when they say to me, Dr. Bill, I only have 1 glass at night. Again, we need to ask more, right? How big is that glass? If they are drinking the wine that I got served last night, they're doing at least 2 glasses every night. Again, this is just going to become more of an issue. The COC, which again accredits all of our cancer programs, did a survey. They're expecting that we're going to hit 23 million cancer survivors by 2032. That's great. That means our treatments are getting better. We're having less mortality, but it also means that we've got more cancer survivors out there, which means we need to engage better with them in order to address all of these ongoing needs that I feel aren't being met well. Loneliness. I don't know how many of you remember, but last year the Surgeon General declared that loneliness has the same risk of mortality as smoking 15 cigarettes a day. Well, here's a paper looking at our cancer patients that showed just by being lonely, you increase your chance of having mortality, whether it's due to your cancer or not. Now again, am I following up with these patients? Am I asking their question, how they're doing and so forth? Yes, but what happens when I identify somebody that I think needs help? Try to find a psychologist that accepts insurance, right? I mean, you'll be lucky if you've got somebody that can help you in the system, but privately, no one's accepting it. So I think this is where our tech friends can help us with virtual nutrition, virtual exercise, virtual mental health, because then we can reach the patients where they are, whether their community has these services or not. So to summarize the cancer survivorship, we know it needs to start the day of diagnosis. It is not something that we wait until you're finished with treatment. PTSD and depression are a part of cancer treatment. We need to be looking at this more heavily. Exercise can reduce all-cause mortality. Our cancer treatments make it worse. We've got to make sure that we understand that. Dietary choices can help us or hurt us after a cancer diagnosis. And survivors that are lonely are at increased risk. So moving forward, here's my request. We need to be looking for virtual services that can address each one of these, because communities don't have them. And we need to be able to meet the person in the home. I can tell you just from my own practice, when I try to get people to come into the cancer center after they've finished treatment to meet with a nutritionist, they don't want to. In fact, I think that's part of the PTSD. They don't want to step foot in that cancer infusion center ever again. So to have that virtual ability that they can do it after hours at home, on their phone, on their laptop, that's going to be much more tolerable to the patient. Exercise, mental health, all of that needs to be addressed. So I guess what I'm saying is we need to put together platforms that can be tailored to the services that the patients need. They need to consistently engage. This is not something we can just do for 3 months and then say, good luck, you're on your own, because we know it's not going to affect the long-term outcomes. There's got to be actionable data. You've got to be able to act upon this. You can't just say, oh, look, we put this program in place, a bunch of people downloaded the app. You need to actually be looking at it. If you can identify that a certain population is missing appointments and it's due to transportation, then put a program in place in order to get those patients in. But you've got to have the data in order to be able to do that. And we need to be continually expanding this. I ran through with you just the changes that were made this year by our overseeing bodies. I am sure next year there will be a new list. So having these virtual platforms that we can continue to add to will allow us to expand it as we see we need to. This may include genetics. This may, include the mental health of the family members that are dealing with this. So again, it's something that needs to continue to explode, but we need our tech partners in order to help us make that happen. Thank you for your time, and again, if anybody has any questions, I'm here the rest of the day.